So we'll continue with the right atrium. We did the right ventricle on Tuesday, uh, so we'll follow up with the right atrium. Again, the right heart is somewhat neglected, so we're going to pay special attention um, to the right heart. All right, so the right atrium. So if you remember what the right atrium does, it basically fills with blood so that blood can empty into the right ventricle. So essentially, it's a conduit and a reservoir, so to speak, because blood flows through it in order to get to the right ventricle, and it also contains a certain amount of blood. So it assists in filling the right ventricle. It's going to receive blood from the inferior vena cava and from the superior vena cava. Uh, if you want to look at the right atrium, then the apical four-chamber view allows you to see the right atrium clearly. You can also see the right atrium in the subcostal view. Um, it's very important for you to do planimetry of the right atrium to get the area. And I think it should be a part of your routine study to do a quick planimetry of the right atrium, because we need to know if the right atrium is enlarged, yes or no. So the right atrium is enlarged if the area is greater than 18 centimeters squared. So again, you should try and do planimetry of the right atrium. And this is how it's done, okay? So apical four-chamber view, and you want to come straight across the tricuspid annulus. Don't go into the annulus. So it's supposed to be straight across the annulus, and you do a planimetry of the surface or the endocardial border of the right atrium, okay? And the machine will give you an area. You can see that you have two measure, you have a longitudinal and you have a sort of uh, a shorter measure. But essentially what we're interested in the right atrium is the area. And again, I'm going to stress it should be done in all studies, because if the atrium is enlarged, we have to come up with some type of explanation why it is. Okay, so we have the major and minor dimension. I wouldn't worry too much about it. You need to know the major dimension, minor dimension. But the thing that you have to definitely record is the area. Okay, so if the minor dimension is greater than 4.4, the right atrium is enlarged. If the major dimension is greater than 5.3, but the important thing is the area. Okay, so you should be reporting the area of the right atrium. That's important. Now, when we did hemodynamics, we went over hemodynamics of the right side as well, the right heart, and we talk about the tricuspid, the TR gradient, okay, the gradient across the tricuspid valve, and if we had to the gradient the right atrial pressure, then we'll get the right ventricular systolic pressure. And if there's no obstruction across the right ventricular flow tract, then we will get the pulmonary artery systolic pressure. Okay, so Again, these are routine things in all studies, okay? So how do we assess or how do we determine the right atrial pressure? Okay, so basically what you have to do, well, in the subcostal view, you're going to look at the IVC, the inferior vena cava, okay? So the most common method to estimate the right atrial pressure is in the subcostal view, you look at the IVC and you want to measure the diameter. You want to measure the diameter of the IVC, okay? And you also want to determine if there is inspiratory collapse and the degree of inspiratory collapse of the inferior vena cava. So the measurement of the IVC should be made at the end of expiration. Okay, so when you inspire, then you take in a breath. When you expire, you blow out the breath. So at the end of expiration, and you want to do it just proximal to the junction with the hepatic vein, just proximal to that. Okay, so if you want to, you can look. And if you have a spirometer, you can see when there's inspiration, when there's, but you know, if you look at the IVC, you can see whether it's collapsing, yes or no. Or you can do the sniff, okay? Tell the patient to take a deep breath in and see how much the IVC collapse, okay? So you want to see collapse with inspiration. The normal IVC should that the normal IVC is less than 2.1 centimeters in width, and with inspiration or with the sniff, it should collapse more than 80%. Okay, so this is subcostal view. The right atrium is right there. This is your IVC. This is the liver. This is the hepatic vein. So just proximal to the uh, just before the hepatic vein, you're going to measure, okay? And the measurement should be in end expiration, okay? And you want to see how much collapse you get with inspiration. The normal IVC should collapse more than 80% with inspiration. So the measurement of the IVC, you're going to measure the diameter is measured perpendicular to the long axis of the IVC at end expiration, just proximal to the junction of the hepatic veins, okay? Which is it's about 0.3, 0.5 centimeter proximal to the ostium. This is the ostium of the right atrium, so you want to measure it just right there, okay? Now, these are the numbers you need to know. Again, the normal IVC should be less than 2.1, less than or equal to 2.1 centimeters, and you should get more than 50% collapse with inspiration or sniff. So if these parameters are satisfied, then the right atrial pressure is about 3. The range is 0 to 5, and the measurement that we're gonna use, because when you gonna record the right ventricular systolic pressure, you just need one number. So the number you need to remember is 3 millimeters mercury. So the normal right atrial pressure is up between 0 and 5 millimeters mercury. And if you look at the IVC, it's less than or equal to 2.1 centimeters. You know how to measure it with inspiration or the sniff, if you get more than 50% collapse, then that right atrial pressure is about 3 millimeters mercury. The next set of numbers you need to remember is these. If the IVC is larger than 2.1 centimeters, and if you get less than 50% collapse with inspiration or the sniff, then the right atrial pressure is about 15 millimeters mercury. Okay? If you look at the tricuspid inflow, and if the EE prime ratio, so you're going to look at the tricuspid inflow, and you're going to look at the lateral tricuspid annular, and if the EE prime ratio is greater than 6, and if you get diastolic flow predominance in the hepatic vein, then all these things tell you that the right atrial pressure is about 15 millimeters mercury. So the numbers you need to really remember is the normal and the high. Anything that falls in between, you're going to give the right atrial pressure about 8 millimeters mercury. So if the hepatic vein is less than or equal to 2.1 centimeters, but you get less than 50% inspiratory collapse, you give it. If it is greater than 2.1 and you get more than 50% inspiratory collapse, then it's still 8. Okay? So the normal right atrial pressure is 3 millimeters mercury. The range is 0 to 5. With a normal right atrial pressure, you expect the IVC to be small. It should be less than or equal to 2.1 centimeters. And with inspiration or the sniff, you should get more than 50% collapse. If the right atrial pressure is elevated, then what you should see is the IVC is going to be larger than 2.1 centimeters when you do your measurements. You will get less than 50% collapse with inspiration. You're going to get a restrictive filling pattern on the right side. And then when you look at your tricuspid inflow and your lateral tricuspid TDI velocity, the EE prime ratio should be greater than 6. When you look at your hepatic vein flow, you get diastolic predominance. So you have to know this table, okay? Because we usually report right ventricular systolic pressure and pulmonary pressures as well. Okay? We also, well, as we mentioned before, your pulmonary artery systolic pressure and the right ventricular systolic pressure, they are usually equal unless there's an obstruction at the right ventricular flow tract or across the pulmonary valve. And we went over this when we did hemodynamics, so this is revision. Again, the right ventricular systolic pressure is equal to the pulmonary artery systolic pressure unless there is obstruction at the right ventricular flow tract or there is obstruction at across the pulmonary valve. The TR regurgitant Doppler signal represents the systolic pressure difference between the right ventricle and the right atrium. We went over this when we did hemodynamics. You're only going to get flow from one direction to another if there is a pressure difference, if there is a gradient. So tricuspid regurgitation occurs in systole. Blood is going to flow from the right ventricle across the tricuspid valve into the right atrium. So therefore, the right ventricular systolic pressure should be greater than the right atrial pressure. The difference is what we call the gradient. And if you remember the modified Bernoulli equation, gradient is equal to 4v squared. So if we get that TR velocity, we square the velocity multiplied by 4, we get the gradient. Okay, so again, so the gradient is the RV systolic pressure minus the right atrial systolic pressure, that's the gradient. We just showed you how to get the right atrial pressure, and you know how to get the gradient for V squared. So the unknown would be the right ventricular systolic pressure. So if you rearrange the equation, your right ventricular systolic pressure is equal to the gradient plus the right atrial pressure. We went over in detail how to get the right atrial pressure. You have to look at the IVC, you have to measure the IVC, you have to look and see how much collapse you get with inspiration or sniff. So you can calculate your right ventricular systolic pressure. It's going to be the same thing as your pulmonary artery systolic pressure, unless there's obstruction of the right ventricular flow tract or across the pulmonary valve. Now, you wanna do when you're doing any type of Doppler measurements, you have to use multiple acoustic windows because you don't know which view is going to give you maximum velocity. And if you don't get maximum velocity, your measurement is going to be off. Okay. So multiple windows. Like, you know, you can get TR from your short axis view at the level of the aorta. You can get it in the right ventricular inflow view. You can get it in the four chamber view. You can even get it in the subcostal view. So you want multiple windows, and you want to use the ISTR velocity. Okay, so this is short axis at the level of the aorta. So this is your tricuspid valve. Color indicates that there is tricuspid regurgitation. You do your C doubler, and you can see your velocity is 2.89 meters per second. And if you square the velocity, multiply it by 4, you get the gradient. The computer does it for you, so this is the gradient. So to the gradient, you have to have the right atrial pressure. So you're going to have the right atrial pressure. So you have to know how to assess your IVC in order to get the right atrial pressure. Okay, so that's a subcostal view. You have to measure the IVC and expiratory measure, and then you see how much collapse you get with inspiration or the sniff. Okay, so when we talk about pressures in any chamber, there's a systolic pressure and a diastolic pressure. Again, we went over this when we did hemodynamics. We can calculate the diastolic pressure, the pulmonary artery diastolic pressure. Okay? So just a quick reminder, when we have pulmonic insufficiency, when we have PI, blood is going to flow from the pulmonary trunk across the pulmonary valve into the right ventricular flow tract. Okay? That is what PI is, pulmonic insufficiency. It's a diastolic phenomenon where blood is going to flow back from the pulmonary trunk across the pulmonary valve into the right ventricular flow tract. It can only occur, however, if the pressure, we're talking about diastole now, okay? This PI only occurs in diastole. So this can only occur if the diastolic pressure in the pulmonary trunk is greater than the diastolic pressure in the right ventricular flow tract. That is the gradient. So that gradient, which is the diastolic pressure in the pulmonary trunk, so it's the PA, the pulmonary artery end diastolic pressure, and it has to be greater than the diastolic pressure in the RV. The diastolic pressure in the RV is similar to the right atrial pressure. So that's why we use the right atrial pressure as opposed to the diastolic pressure in the RV, but it's the same thing. So the gradient which cause blood to flow backwards from the pulmonary trunk across the pulmonary valve and into the right ventricle, that gradient, all gradient is equal to 4V squared. But if you remember, when you have PI, you get a truncated envelope in diastole, okay? Or all our measurements are going to be end diastole. So you have to use your end diastolic velocity. You're going to square that velocity, multiply it by 4, and that will give you the gradient, 4V squared. Okay, so it's the velocity at the end of the diastolic pulmonary regurgitant jet. So if you remember, when you have PI, you get something looking like this, and you have your early velocity and your end diastolic velocity. This is the velocity you're going to use, your end diastolic velocity. You square it, multiply by 4, and that's the gradient. Okay? But remember that the gradient is equal to this. So if you rearrange your equation, you can get your pulmonary artery end diastolic pressure. And we already showed you how to get the pulmonary artery systolic pressure. So you can get both systolic and diastolic pressure. All right, so it's the end diastolic velocity squared multiplied by 4. Okay. There are other things we can measure, you know. We can measure mean pulmonary artery pressure. As a matter of fact, it's more accurate if you want to determine if the patient has pulmonary hypertension. Mean pulmonary artery pressure is more accurate than using the systolic pressure. So knowing how to get your mean pulmonary artery pressure is very important. So already showed you how to get your pulmonary artery systolic pressure, showed you how to get your pulmonary artery end diastolic pressure. Your mean pulmonary artery pressure is equal to 1/3 the systolic pressure plus 2/3 the diastolic pressure. So this is once you calculate your systolic and your diastolic pressure, the mean PA pressure is 1/3 the systolic plus 2/3 the diastolic. So you have to remember that. Or you can use your PR velocity. Remember, the PR velocity has an early and an end diastolic velocity. If you use the early velocity, you square it, multiply by 4, and add your right atrial pressure, then you get the PA pressure. Okay? Using the early PR velocity. So using this one, the early. Okay? To get the end diastolic pressure, we use this. To get the mean PA pressure, use the first one. We can also, to get the mean PA pressure, we can also use the mean when we do our TR velocity. If we use the mean velocity, or okay, or the mean gradient. If we use the mean velocity across the TR, then we can use that. Let's and we'll go over that. We'll go over that. Let's see. All right, let's do the tricuspid valve. All right, so we've been talking about tricuspid valve. We've been talking about tricuspid valve. You know, the tricuspid valve separates the right atrium from the right ventricle. Tri means 3, so there are three leaflets. There's an anterior leaflet, there's a posterior leaflet, and a septal leaflet. And you know, when you're doing exams, they usually ask you to name some of the leaflets. So you need to know, what leaflet you're seeing in the different views. Okay, all right. The peak velocity across the tricuspid valve is somewhat lower than the peak velocity across the mitral valve. So the tricuspid inflow velocities tend to be somewhat less than the mitral inflow velocity. So usually less than 0.7 meters per second. And because it's on the right side, these envelopes or velocities are going to vary with respiration. They're going to be larger with inspiration and less with expiration. Again, similar to your mitral valve, the tricuspid complex, you have coordinate tendineae, which attach to papillary muscles. There's supposed to be 3 because there are 3 leaflets, so 3 papillary muscles. And you have the coordinate tendineae, which attach to the 3 leaflets. And again, you have a fibrous annulus. Okay, so some disease that can affect the tricuspid valve, you can get tricuspid stenosis. A carcinoid is one of the things that can give rise to that. That would be acquired tricuspid stenosis. Rheumatic fever can give you, tricuspid valve pathology as well. We'll talk about carcinoid tumors. Vegetation can affect the tricuspid valve. You can get damage from pacemaker, okay, aneurysm of the sinus of Valsalva, or prostatic obstruction. We're just going to quickly talk about tricuspid stenosis. Of course, blood cannot get out of the atrium, so you're going to get a fluttering. The patient would complain of a fluttering discomfort in the neck because the neck veins are going to be engorged, going to be enlarged. It's going to be distended because blood cannot get out of the right atrium. Because blood cannot get into the RV and go to the lungs and go to the left side of the heart, cardiac output is going to be reduced somewhat, and so the patient will be fatigued, cold extremities, cold skin because of decreased cardiac output. And the you get right upper quadrant abdominal pain because blood cannot get out of the right atrium. Right atrium is going to be engorged. The liver is going to be engorged. So the liver is going to be distended, and that is why patients will have this right upper quadrant abdominal pain because of a distended liver. The jugular veins are going to be engorged and dilated, so jugular pulsation and presystolic murmur heard at the left sternal border in the fourth intercostal space, and it's going to increase with inspiration. So again, they show you tricuspid valve it's thickened. We don't normally see this, and this is a systolic frame because the mitral valve is closed, but the tricuspid valve is still open. You can see that the right atrium is enlarged. That's because blood cannot get out. And then when you do your Doppler, this is your tricuspid inflow. Okay, so you can, if you trace it, it will give you the gradient. There is some TR there as well, so that's what systolic TR. Okay, so you have some tricuspid regurgitation and tricuspid stenosis. So once you do planimetry, you can get the gradient is 9, so this is very large, and you can even calculate the area. It's not customary to do tricuspid area. The gradient is sufficient for tricuspid stenosis. Okay, so this little table, and we will do all the updates. So you're going to have significant tricuspid stenosis if the mean gradient is greater than or equal to 5, and if your inflow time velocity integral, that is when you trace it, if your time velocity integral is greater than 60 centimeters, If the pressure half time is greater than or equal to 190 milliseconds, then this suggests tricuspid stenosis. And if you want to go through and calculate the valve area, anything less than or equal to 1 centimeter squared suggests significant tricuspid stenosis. Supporting evidence is an enlarged dilated right atrium and a dilated IVC. So these are supporting evidence. Okay, so we're gonna stop here, and we will do tricuspid regurgitation our next session.